Good evening. Thank you for invitation and inviting me to talk on case-based discussion on frail multiple myeloma patient, focusing on the Andrew and Arrow trial. Good evening, ladies and gentlemen. In next 20 minutes, I will take you 7 steps by eye-opener, multiple myeloma challenges in 2021, multiple myeloma journey, what to remember, real-world experience based on the Endure and Arrow trial, and then goal and expectation. Just beginning, opening question, what color is the ribbon for multiple myeloma? Here is the evidence. If you had looked in what is the color of this my tie? So here is also another evidence-based answer. I'll give you all answer with the evidence. Burgundy is the deep reddish brown color. How are oncology classified? Solid organs like medical oncology, lymph node disease like lymphoma, and stem cells curable and incurable. Today our topic is incurable disease. How stem cells are classified and where our topic multiple myeloma stands. If you see, if the blast cell is less than 20%, we call it chronic leukemia. If it is more, we call it acute leukemia. And our topic is plasma cell disease, which is called either MGUS, multiple myeloma, or plasma cell leukemia. So in next 18 minutes, I will take you some challenges. Multiple myeloma, is it really burden of the disease? Yes, it is the second most common malignancy. And just in 2016, 150 cases were diagnosed overall the worldwide and 100,000 people died because of multiple myeloma. So what is the solution? Here you can appreciate over the 4 decades, the survival of multiple myeloma increased from 30 to 90%. But multiple myeloma is unfortunately relapsing disease. You cannot cure it. And multiple myeloma with high risk cytogenetics has unfortunately poor outcome. More important is if you see the PFS is decreased from 50% to 30% in frail patient, which is our topic. So multiple myeloma is not a one disease, just one size does not fit to all. Over the 3 decades, they are stratified the multiple myeloma, different risk stratification, like everybody know, ISS and revised ISS score based on A, B, C, D. A is albumin, B is beta-2 macroglobin, C is cytogenetics, D is LDH. But I have divided multiple myeloma in 4 clinical patients, like blue line. Is case 1 is the standard. You treat the multiple myeloma, patient will go remission for years, then relapse, then orange line. Same like blue line, you treat the patient, went for remission, but unfortunately, see, this is the black line, means last to follow up. Again, patient came back and you have to treat the patient. Red line, very difficult patient who relapsed within a few months to years. Green line, very easy patient, you treat the patient a long remission. So I will present cases accordingly. Multiple myeloma change is historical challenge actually. If you saw multiple myeloma, it took 1 century to make a diagnosis from 180 to 40 to 940. They labeled the patient as a multiple myeloma. Then melphalan, steroid came, and we are unfortunate. We have landscape available in 2021. If you divide by IM, PI, and then chemotherapy, then steroid, novel agents, monoclonal antibody, and of course, CAR T cell therapies. However, 15 approved novel agents in multiple myeloma and more are coming. How do we sequence and stratify these drugs to ensure the best outcome for multiple myeloma? This is the challenge. However, we can solve the challenge by NCCN and ESMO guideline. They divided. The first step is to check the eligibility and you choose preferred regimen are useful in certain circumstances. But our topic is actually relapsed multiple myeloma. That is based on the Richardson. He nicely made as if you go through the left side, treatment for first relapse, you have to check whether it's refractory to lead or not. Based on then you choose it. And if treatment after multiple relapse, then you have a different option. And the big challenge is, lean refractory, which have least PFS. So how there is solution, how you define. If progressive disease, there is clearly mentioned IMWG that 25% increase in native 1%, like M protein, FLC, and bone marrow plasma cells, or any new lesions are circulating plasma cell, we call it a progressive disease. And when we call refractory disease, the patient who is on treatment or within 60 days of treatment, we label this drug as a refractory. Now, multiple myeloma also has paraclinical factor as well as both two common disease, diabetes and cardiovascular disease. So if patient has diabetic neuropathy, you will choose the carfilzomib because least neuropathy I will show you. And if cardiovascular disease, you will choose the Velcade. However, multiple myeloma gets harder to treat with each relapse. Indeed, multiple myeloma is marathon. It is not sprint. So what is the difference between marathon and sprint? Actually, marathon is a long-term strategy and sprint is short-term strategy. So don't make it short-term, make it long-term strategy. Choose wisely and smartly. The first regimen here and see in this patient, it was seen long-term you choose the properly and patient go long-term remission. When should we start treatment? Relapse patient with the clinical progress or CRAF symptom clearly needs the treatment. The last challenge is from the beginning, we have the challenge induction, which PI, which immunomodulator, monoclonal antibody, yes or no, auto, yes or no, timing of the auto, consolidation or no consolidation, maintenance, then which maintenance, where there is a will, there is a way. If you individualize the patient from the beginning, which I do with my patient, induction, transplant eligible, comorbidity, lifestyle of the patient, social factor, how long patient wants to treat, autologous, delayed, upfront, 1, 2, you have to discuss all these things. Consolidation, what agents you prefer, how many cycles, maintenance, how long, which agents, all these things if you discuss and you will make life easy for the patient. Now, third step is multiple myeloma journey, what to remember. You have to remember A to G for multiple myeloma. A stands for accurate diagnosis, staging, and prognosis. B, before beginning the treatment, check the indication is not. C is choose the smart treatment with the least. D, drug toxicity. And E for efficacy. If you have to check MRD, I'll just go through the simple electrophoresis to check it. And F for feasibility and future direction. G for guiding line. And HIT means heading ideas for Twitter. If you're successful, tweet it. Now, A is accurate diagnosis and staging. You have to find whether your multiple myeloma is ALL like multiple myeloma like this one, or you have follicular lymphoma like this one. So you have shoot accordingly. Now, case 1. This was about 2012 first case, 58-year male who was referred to us with backache and the lytic lesion in the scapula. We checked, normal electrophoresis. You 52 gram per liter IgG kappa. Marrow revealed 30% plasma cell. So here we are going to A, accurate diagnosis staging. It was ISS stage 3, and the patient will live, median is 4 years. And there is slim CRAF features. Yes, there is a feature. B for beginning. Yes, beginning the treatment, you have to treat the patient. Now C, choose the treatment. You have different options from doublet to triplet to quadruplet. Choose the therapy, the least drug toxicity, go through the guideline, NCCN guideline. You have preferred regimen, other regimen, but if they don't help you, go through the online drug decision. You put your data, this is started in 2019 actually, but my case was 2012. Anyway, what they choose? Now they choose in 21 RVD or plus minus DARA, they suggested, but we were about 2012, our patient in 2012. This was our RF advice. 1.5 decade actually, we started VRD in all patient first line. So in this patient, VRD was given, and here E for efficacy. We don't have MRD, we use the biochemical test, electrophoresis. You can see clinical and biochemical, the patient after 4 cycles have almost complete remission. VRD, everybody know, based on the S0777 have more PFS in overall survival. Even if you age now monoclonal antibody, your PFS will increase up to 95%. Now, after 4 cycles, is transplantation is still needed of this treatment? Data has indicated, yes, still transplant needed, even shown in both, but the important thing, determination trial has shown, it is also experimental. The patient who has negative MRD, they have shown almost equivalent whether they are transplant or RVD chemotherapy. Anyway, come back in 2012, our patient who completed 4 cycles of chemotherapy, we don't have autologous transplant available here, and so patient didn't want to go, so we did his bone marrow, he had complete remission after 4 cycles. And he continued 4 more cycles, so 8 cycles of chemotherapy. Then what to do next? Maintenance lenalidomide. Yes, we gave this patient, and here you can say 3-year PFS. He was doing well. Now, at the end of the 2014, after 3 years, his disease progressed. Bone marrow done, it was confirmed its progress. Then what to do? Then again, 2014, open the NCCN guideline. You have option again, KD or DARA KD based chemotherapy is full of treatment there. And but if you go even the Ritchie-Richardson criteria, if you go the left side, which is the purple color, post relapse refractory to lenalidomide, because this patient was on lenalidomide, I would label this patient as refractory to lenalidomide. I will choose either KD or DARA KD based chemotherapy. Now, if you go through in detail, which is the best one, Pollock's trial has shown DARA RD is better, but we will not use because RD is out in our case. Then Kester trial, DARA VD is better. We can use this one. Then Kender trial, DARA KD is better. It's better. You can use it in this patient as well. Similarly, in Apollo trial, you can use POMA DARA is also better PFS. So in all, even new monoclonal antibody, elotuzumab is also said better. So you have option. Now, this is too much confusion. Why not go for, again, expert online in 2021, they say use DARA KD. Here you can see all 5 experts, they recommend same. But we were in 2014. 2014, everybody know DARA it was not birth of the DARA. Even, I mean, there was no, even Kester trial was present in 2016, 17 and 18. So DARA was out of question. So this we go, 2014, we use Saber protocol and its complete remission Saber protocol. He went also high dose chemotherapy as well. And after this, we gave him Velcade chemotherapy. Now this is the journey. After Velcade, he remained 4-year disease-free survival. But again, 2017, disease clinical and biochemical relapse. Now we have option of the treatment. Now we are in era of monoclonal antibody, what we should do in this patient. Okay, expert online, you can use DARA KD. Everybody, all 5 experts say DARA KD, but unfortunately in Tamam, we don't have 2017 DARA. So we gave this patient only KD. So it was KD, which is Endure and Arrow-based trial, which is weekly actually based on the Arrow. So we used 1 year, then he was complete remission. And again, 1 year more complete remission. Patient wanted to stop the KD and patient want to either continue therapy or maintenance with therapy. What maintenance? No maintenance, already bortezomib, lenalidomide out. So only remain is acetuzumab. However, patient decided to opt therapy. Now, over the 2 years, he's opt therapy, he's doing well. Now, this is about 10-year journey of impact of novel therapies and importance of sequence of multiple myeloma. And this blue line patient, this is the patient 1. Now, I will go to second patient, which is the orange line. 68-year male, non-asthmatic, multiple myeloma, stage 2, 2017, normal cytogenetic, RVD, 8 cycle was given. This patient also didn't go for transplant. Then lenalidomide. Why I say orange line means last to follow up. He last to follow up again. He patient came back with a backache and also lower extremity, mildly called compression. So eventually he take radiotherapy, and then we started KD based chemotherapy, and we thought we may start the pomalidomide. The patient was bed bound, so we started actually KD based chemotherapy. Now you can see after the 8th cycle of the only just KD therapy, he's complete remission. He's ongoing on the KD therapy. Now, again, one case, blue line, multiple myeloma, 2017, who received RCVDB chemotherapy. Then patient went to Egypt, autologous transplant, took lenalidomide, but after 6 months, disease relapse, and he took DARA VDB's chemotherapy, some other hospital, not our hospital, so the German hospital, and then the patient referred back to us when he has clinical and biochemical relapse. We just again give Arrow-based therapy, KD-based chemotherapy, and you can see very beautifully he's doing very well. And this is the graph of this patient. Now again, one more patient, 62-year multiple myeloma, who had actually second transplant in this patient. First, he took VGT-based chemotherapy. After 4 years, we again gave him VID-based chemotherapy. He went for second autologous transplant. Then after 2 years, again, disease came back, and he also on KD-based chemotherapy. He was doing well, but in between, he lost to follow. His graph went up, but again, he's on KD. He's doing great. Now, fifth is red line. 67-year male who has actually multiple myeloma, very high risk cytogenetics. And the important thing is MRI revealed all bone vertebra compression from cervical to lower thoracic, multiple compression there. He was given first radiotherapy, then patient will give VRD. And here you can see even after 2 cycles of the VRD, disease increase. So it means he is refractory to VRD. Velcade Revlimid. So this is challenging. We give this patient actually again kinder-based DARA KD. Here only KD may not work, so we give DARA KD. And it's good luck to him, and he's doing great. Nowadays, he's completed 4 cycles of chemotherapy. This is the MRI of this patient, cervical lesion. You can say this is the more new bone lesion in thoracic. Again, there is too much compression, and in this lumbar as well. Also, there is multiple fracture over there. Very aggressive disease. This patient. Again, one more red line patient. This is a 62-year male who has plasma cell leukemia, very difficult disease, extramedullary disease as well. He was given VRD, but if within 1 year disease progress, then he took IMiD and KD-based chemotherapy. He was doing well. Then again, he lost to follow-up. Then again, we started DARA KD-based chemotherapy. Now he's almost 7 years. He's doing very well. Plasma cell leukemia, everybody know it is very difficult to treat the plasma cell leukemia, but thanks God, he's doing very well. DARA KD-based chemotherapy. Now, again, one more Biluline patient. This is a female, 68-year, who took VRD 8 cycle, then lenalidomide, but disease progress. Then she took also KD-based chemotherapy. Over the 3 years, her PFS was good. Then disease progress up on KD, so we use DARA PD. I wanted to show you here this, we choose always different things, not same thing. See, VRD, then KD, then DARA PD. We choose the different. We have now luxury of all the options available. We don't try to patient who is refractory or relapse on the treatment. Now, this is 8 case. This is again, initially started VRD 8 cycle, again disease progress, and now he is doing very good on the KD-based chemotherapy. The last case is green line, which I wanted to show you, middle-aged lady who has renal dysfunction as well. And from the beginning, it was given KD-based chemotherapy, and she took about 2.5 years KD-based chemotherapy. This is the green line, doing very good, very small disease. Now, presenting all these cases, what you think? I hit the disease, hurt the patient. I think I hit the disease. There is one bonus question. This is from Richie Richardson. He presented in one forum. There's 68-year male who is a standard risk IgG kappa, autologous transplant, and then disease relapse. What is the option? He asked the audience, and audience say go for DARA KD or go for KD. So it is same like, so last 20 minutes I presented these lines of the patients. Now, Aero study, what is the Aero study? Aero study is actually designs once weekly or twice weekly. Here is the design. The important thing which I wanted to show you, even you give weekly, the PFS from 7 to 11 months, so it's improved. So it's better to give weekly. Why you weekly? The less reduction of the reduction of the disease, less discontinuation of therapy. The important thing in Aero trial, they have shown there is significant improvement PFS and overall survival. So, and more convenient schedule. Why not? We should use weekly. So now there are two options, VD versus KD. This is an Endure study, very small. It's novel to novel agent. First time it was compared about 900 patient KD versus VD. What they have shown, it is clearly shown PFS, KD PFS double to the VD. So why not choose even in the high risk cytogenetics, even is aged patient, even who prior line of therapies, and the important thing is neuropathy. You can see VD is KD is 6% neuropathy and VD is 32% neuropathy, and the quality of life is better in the KD based chemotherapy. So why not choose KD based chemotherapy, weekly based chemotherapy? Now, last 20 minutes, what I wanted to emphasize, I went through the opener questions, multiple myeloma challenges 2021, what to remember, A to G, and I have shown the real world experience of the Endure and Aero trial, how I use it, and also briefly focus on the trial as well. And my question is for 2021, which bird is better, DARA KD, DARA PD, DARA POMA KD, you can use anything. And the important thing, this is my last slide, as Mr. John Fredrickson, he is saying, teaching is the great sin in the boring. Hopefully I didn't bore you like Joseph also don't bore you. Thank you very much. If you have any question, I'm happy to answer all of your questions. Thank you very much.